A very good morning and a warm welcome to all our esteemed guests and to dear learners. First of all, a very Merry Christmas. I hope you had a great time in this Christmas and a very Happy New Year for the coming 2021. We wish you the best of luck, success, and learning at the best. I'm Dr. Riya Chakral from the Homeopathic Academy, and we are here today to discuss a very essential topic, the session 3 of Protocol for Homeopathic Management of COVID-19 with Dr. Harsh Nigam. We have Dr. Harsh Nigam live with us right now. But before we go ahead with this webinar, if you're joining us for the first time, it is customary for me to tell you about the Homeopathic Academy. So let me quickly introduce ourselves. So the Homeopathic Academy, or THA as we call it, is BJN's effort towards digitalizing homeopathy and providing a platform for quality education online. THA offers you a range of online courses by well-known academicians on numerous subjects of homeopathy at undergraduate, postgraduate, UPSC and CME level. All these courses are enriched with state-of-the-art audio-video technology, text and vector animations, giving you an HD quality audio and video experience made by a dynamic team of qualified doctors, video editors, and many more professionals. These courses will perfectly complement your studies to make learning an extraordinary experience. On your screens, you can see some of our courses currently streaming on our website, www.thehomeopathicacademy.com. You can also see the course on Modus Foundation and Modus Prescriber by Dr. Harsh Nigam. Here, Dr. Nigam will teach us how to adapt the concepts of organon and homeopathy in general in modern clinical scenario and improve our clinical practice, an essential need for all of modern homeopaths. So these are just the few courses that we have currently streaming on our website. You can visit us on www.thehomeopathicacademy.com and enroll in any of these courses of your choice. Just shifting through them real quick. So this is Dr. Harsh Nigam's course, which I was talking about. If you have not enrolled in it yet, then you should, trust me. These are some of the courses, quickly going through. So that's it, a little about us. Thank you so much for listening. Coming back to this webinar, Dr. Harsh Nigam, first of all, let me introduce him to you before I call him up to start the learning. Let me quickly introduce him if you're joining for the first time. And also, I'm pretty sure you would be asking me very soon that, this is the session 3 of this series. So where can we find the session 1 and 2 if you have not joined us before? So don't worry, you can visit our website, and on the page Vialogs, you can find the recording of all the sessions that we have had yet, the session 1 and 2. It is available. You can visit us there and find it. And you can watch it anytime. So a little about Dr. Harsh Nigam for you all. So Dr. Harsh Nigam is a renowned practitioner and an author of 8 books on homeopathy and 12 research papers published in various Indian journals. Despite having obtained MBBS and MD in Physiology, he could not suppress the heritage of homeopathy that he received from his father, Dr. Jagdish Chandra Nigam. He has obtained his membership of faculty from the Royal London Homeopathic Hospital, UK. He's currently spearheading a multi-speciality OPD-Hospital at Kanpur, a center of excellence in medical homeopathy. He provides research-based medical solutions to various health issues. He aims to establish homeopathy on its scientific merit and make it integrated with orthodox medicine in such a way that the scope and limitations of homeopathy are well defined, well, much needed indeed. And talking about his published books, so 2 of those internationally recognized books are Principle and Practice of Homeopathic Case Management and Miasma, A Road Less Traveled, which you can see on your screens. Also, they are available with BJN publishers if you want to buy them. and he's a nominated member of editorial board of IJH and an ex-member for Special Committee of Clinical Research at the Central Council for Research in Homeopathy. He's also conducting a research in his own clinic on COVID, and that's what we will be talking about today. So without wasting any more time, sir, please come live with us so we can start learning from you as soon as possible. So we can't hear you. Please turn on your audio. Yes, sir. Now we can hear you.
Can you hear me now?
Yes, sir. Yes, sir. Yeah, now
okay. So first of all, Merry Christmas to you all. And today's topic is a bit lengthy. I would not be going into the nitty-gritties of the medicines, but I would be going into the prescribing part of the Borland's protocol, which is very important. So first of all, to recapitulate whatever we had studied in the last part, Dr. Ria, can you play the video that we've downloaded from YouTube?
Yes.
Pneumonia is an infection in the lung tissue caused by microbes. And the result is inflammation. The inflammation brings water into the lung tissue, and that extra water can make it harder to breathe. During inhalation, air reaches your lungs by traveling down your trachea. Then it continues through the bronchi and the bronchioles and ends up in the alveoli. The alveoli are tiny air sacs that look like tiny clumps of grapes that are wrapped up in a net of capillaries. This is where the majority of gas exchange happens in the lungs. Oxygen leaves the air in the alveoli and crosses into the bloodstream, while carbon dioxide leaves the bloodstream and then is exhaled out of the body. Now, in addition to air, you're constantly breathing in other stuff, like microbes. But we're usually pretty good at protecting ourselves. For example, we have mechanical techniques, like coughing, a mucociliary escalator that lines the entire airway and moves out larger bacteria, and macrophages that are nestled deep inside the alveoli and ready to destroy anything that lands there. But sometimes a particularly nasty microbe might succeed in colonizing the bronchioles or alveoli. And when that happens, congratulations, you've got pneumonia. Those microbes typically multiply and cross over from the airways into the lung tissue, creating an inflammatory response. The tissue quickly fills with white blood cells as well as proteins, fluid, and even red blood cells if a nearby capillary gets damaged in the process. Now, there are lots of different pneumonia-causing microbes. Usually it's caused by viruses and bacteria, but it can also be caused by fungi, as well as a special class of bacteria called mycobacteria. In adults, the most common viral cause of pneumonia is influenza, sometimes just called the flu. In adults, bacterial causes include Streptococcus pneumoniae, Haemophilus influenzae, and Staphylococcus aureus. There are also more unusual bacteria like Mycoplasma pneumoniae, Chlamydophila pneumoniae, and Legionella pneumophila, which don't have a cell wall and are well known for causing an atypical or walking pneumonia, because they often cause vague symptoms like fatigue. In individuals with a normal immune system, fungi are a rare cause of pneumonia, and often it's regional. For example, there's coccidioidomycosis in California and the Southwest, which you can remember because there's a C in both cocci in California, histoplasmosis in Ohio and the Mississippi River valleys, H in histo and H in Ohio, and blastomycosis, which are broad-based budding yeast in the East. You can remember that with Eastern yeast. And the broad-based budding refers to the fact that under a microscope, when the fungi bud off each other, there's a broad versus a narrow base. To round out the fungal causes in the US, there's Cryptococcus, which is cryptic because geographically it can pop up really anywhere. Now, one special fungal culprit is Pneumocystis jirovecii, which is a risk for immunocompromised individuals. Finally, there's mycobacteria, which are slow-growing like fungi, hence the myco in their name, even though they're still bacteria. The most well-known one is Mycobacterium tuberculosis, also just called TB. Now, pneumonia can also be categorized by how it's acquired. The most common is community-acquired pneumonia, and it's called that when a person gets sick outside of a hospital or healthcare setting. Next is hospital-acquired pneumonia, or nosocomial pneumonia, which is when a person gets pneumonia when they're already hospitalized for something else. This type tends to be more serious because sick patients often have a weakened immune system, and the microbes in hospitals are often resistant to the common antibiotics. That's because hospitals bring together the bacteria that are often the most virulent, think great offense, as well as the most resistant, think great defense. And these bacteria are able to swap some of the antibiotic resistance genes with each other. A well-known example is methicillin-resistant Staphylococcus aureus, or MRSA. Non-resistant Staph aureus can cause pneumonia and other infections, but it can also be killed by common antibiotics, like ampicillin. MRSA, on the other hand, is resistant to many antibiotics, and is therefore harder to treat. Another category of pneumonia is ventilator-associated pneumonia, which is a subset of hospital-acquired pneumonia, but it specifically develops when ill individuals are connected to a ventilator. Oftentimes there's a biofilm, which is a mix of bacteria, sugars, and proteins that can coat a surface, that forms on the endotracheal tube. Individuals on a ventilator can't cough, and are often pretty sick already, so over time microbes can move from the tube directly into the lung and cause a pneumonia. Now, in addition to inhaling microbes, there are also other ways to develop pneumonia. Think about this. You're eating some French fries, and instead of swallowing one, you accidentally breathe it in. Informally, we call that going down the wrong pipe, but we could also say that you aspirated that French fry. Normally, you'd automatically gag and start coughing, and work that French fry out of your lungs. These gag reflexes can be compromised, though, by drug and alcohol abuse, brain injuries, or swallowing issues. So in these cases, the French fry might stick around in your lower airways. Now, of course, that French fry isn't sterile, and there might be some microbes stuck to it. If those microbes infect the lungs and you get pneumonia, we would call that French fry pneumonia. Nope, just kidding, it's called aspiration pneumonia. Aspiration pneumonia can also happen with drinks or even gastric contents, like after a bout of vomiting. Aspirated gastric contents can be particularly nasty because the stomach acid can cause a chemical irritation in addition to the possible infection. Another way we can characterize pneumonia is by where the infection is. In bronchopneumonia, the infection can be throughout the lungs, involving the bronchioles as well as the alveoli. In atypical or interstitial pneumonia, the infection is mainly just outside the alveoli in the interstitium. And in lobar pneumonia, the infection causes complete consolidation of a whole lobe of the lung, meaning that the entire region is filled with fluid. The vast majority of these are caused by the Streptococcus pneumoniae. Usually, lobar pneumonia happens in stages. The first stage is congestion, and it happens between 1 and 2 days. This is where the blood vessels and alveoli start filling with excess fluid. The next stage is red hepatization, and it happens between days 3 and 4. This is where exudate, which contains red blood cells, neutrophils, and fibrin, starts filling the air spaces and makes them more solid. The name hepatization refers to the lungs taking on a liver-like appearance from the reddish-brown color of the exudate. The third stage is gray hepatization, which happens around days 5 to 7. In this stage, the lungs are still firm, but the colors change because the red blood cells in the exudate are starting to break down. The last stage is called resolution, and this happens around day 8 and can continue for 3 weeks. In this stage, the exudate gets digested by enzymes, ingested by macrophages, or coughed up. Pneumonia most often causes dyspnea, or shortness of breath, as well as chest pain and a productive cough, meaning that pus or bloody sputum might come up. Often there are also systemic symptoms, like fatigue and fever. Diagnosis of pneumonia is usually made in a person who's working hard to breathe or breathing quickly. A chest x-ray of bronchopneumonia typically shows patchy areas that are spread out throughout the lung. In atypical or interstitial pneumonia, the pattern is also often spread throughout the lungs, but it's often concentrated in the perihilar region and looks reticular, meaning there will be more line-shaped opacities visible in the chest x-ray. In a lobar pneumonia, fluids localize to a single lobe or set of lobes. Another way to detect lobar pneumonia, though, is to look for dullness to percussion, which suggests that there's lung consolidation. There's also tactile vocal phrematus, which is when you can feel more vibrations from a person's chest or back after they repeat certain phrases. This is because sound travels better through the fluid-filled consolidated tissue than air-filled healthy tissue. Late inspiratory crackles might also be heard, along with bronchial breath sounds, bronchophony, and egophony. The treatment of pneumonia depends on the type and severity of pneumonia. Since bacteria are the most likely cause, antibiotics are often prescribed. In addition, cough suppressants and pain medications are often used to help with symptoms. Alright, as a quick recap, pneumonia is an infection of the lungs that results in air sacs being filled with fluid. The disease can be classified by being either community-acquired, hospital-acquired with some of those being ventilator-associated pneumonias, or aspiration pneumonias. Pneumonia can also be characterized by where the infection is in the lungs. Bronchopneumonia is spread throughout the lungs. Atypical or interstitial pneumonia happens in the interstitium around the alveoli, and lobar pneumonia usually infects an entire lobe of the lung.
Hi everyone, my name's Evan. I hope you enjoyed the video. Let's do a quick review question. How do you know you have bronchopneumonia?
Dr. Dia? Hello?
Yes, sir.
You can hear me now? No?
Yes, sir.
So can you put the presentation on, please?
Yes, sir. I'm putting it on. Here you go.
Okay, thank you very much. So guys, we are going to start with the application of Borland's protocol to pneumonia and especially to COVID pneumonia. Now we must understand here that COVID pneumonia is a very rapidly developing pneumonia and it is usually bronchopneumonia. You now know what bronchopneumonia is. It is rapidly developing. It starts with cough and then it trickles down. But Borland, with his wisdom, had created a kind of a classification of how to deal with pneumonia. And this is a therapeutic classification of how to tackle pneumonia once the patient comes to you. So, you see, he divided the patients that came to him into groups. Now, group 1, he called them as patients in incipient stage. Group 2, frankly developed pneumonia. Group 3, patients having complicated pneumonia. Now, you must understand what he meant by complicated pneumonia. He meant by complicated pneumonia the patients who would need not a single who would need to be cured would not require a single medicine, but it would be difficult to choose a single remedy for them. It would be difficult to choose a right potency for them because they would be complicated. So many a times you would be requiring one medicine. It would have to be followed up by another medicine. And amongst complicated pneumonia, he subclassified them into mixed pneumonia and bronchopneumonia. Now, mixed pneumonias are pneumonias which are having pneumonias with other infections. Now we know what he meant by mixed pneumonia. Under mixed pneumonia, he also categorized aspirational pneumonias and pneumonias which were influenzas, the pneumonias that were complicated by bacterial or other microorganisms. And then bronchopneumonia, we all know, where both the lobes are infected with pneumonia patches. Then group 4, late pneumonia. Patients who are not resolving well, who are lingering on and not getting cured by your usual medicines. He classified them into late pneumonia, and also the patients who come to you late in their disease. That means they have gone to other systems or other doctors and they are presenting to you after being treated by other people and they are in a dire strait. Now, this is how he classified the patients who came to him, the patients of pneumonias who came to him. Then In group, the reason for classification of these patients was that he had a definite set of medicines for each group. And these definite set of medicines that he had are not necessarily the medicines that you should have in your mind. But since we are going to talk about Borland's protocol, so we are sticking to Borland's thought that he had in mind. But actually, the patient who comes to you needs proper repertorization after proper history taking, and then you individualize the case and you get the medicine. But for quick bedside prescribing, Borland's protocol is excellent. Now for incipient stage, he has aconite, ferrum-phos, belladonna, and ipecac in his armory. For frankly developed pneumonia, where consolidation has taken place, here he has Bryennia, Phosphorus, Veratrum viride, and Chelidonium. Now Chelidonium and Veratrum viride would be a surprise for some people. So we are going to take a bit of time while talking about these medicines. Since this is a long presentation, I'm not going into the nitty-gritties of many medicines, but I'm going into the typical points of these medicines. But I would be more interested in telling you the prescribing agenda, the prescribing strategy, and how to prescribe in the Borland's way. Because since past 23 years, I've been prescribing in Borland's way. My father had been prescribing in Borland's way for last 50 years. He's no more now, but he prescribed in Borland's way in acute diseases for last 50 years. I caught it from him. And this prescribing is magical prescribing. And as you are, you become adept to this kind of high potency prescribing of Borland's and Kent and Margaret Taylor's, you and Marjorie Blackie's, then you get to know the magic of homeopathy and the power of homeopathy over acute diseases. And you are so confident that you can predict that the patient is going to be cured in so and so many days. So for frankly developed pneumonia, he has Bryennia, Phosphorus, Veratrum viride, and Chelidonium. For complicated pneumonia, group 3A, the mixed pneumonia, he has Baptisia, Pyrogen, Lachesis, Marksol, Hippersulf, Rustox. Now herein he also makes two divisions. Now Baptisia, Pyrogen, Lachesis, Marksol, you may discuss separately about whether they are hot or chilly, but they are definitely not completely chilly. There are phases here and there. We are going to talk about that. But two definite chilly medicines are Hippersulf and Rustox. These are definitely chilly remedies, while Baptisia, Pyrogen, Lachesis, Marksol, pneumonias, it is kind of a muttering, dull, low kind of pneumonia, wherein patient may have different kind of temperature reactions. With bronchopneumonia, Borland has natrum sulf, pulsatilla, senega, and lobelia. In this COVID-19 phenomena, what I have seen, Bryennia, Phosphorus has worked wonders. Baptisia for low cases has worked very well. Pyrogen has worked very well. Rustox has worked very well. Pulsatilla, senega, and lobelia, they have worked very well. Then for late pneumonias, it is antimonium tart, carboveg, kalicar, lycopodium, arsenic, and sulfur. With Borland's confidence, I have been able to use sulfur as acute remedy in COVID-19 with dramatic results in late pneumonias. So antimonium tart has worked very well. Kalicar has worked very well. Lycopodium and arsenic album have worked very, very well in COVID-19. So you have a very profound kind of grouping of pneumonias by Borland about 100 years ago, wherein he has encapsulated all the medicines which are required in COVID-19 also. So Let us understand, before going into the nitty-gritties of the medicines, let us understand what is the Borland's plan of examination of patients with pneumonia. This he has not written in his book, but you would have to understand he goes and he examines his patients with a plan. He first assesses the onset of the disease, whether it is acute onset, whether it is slowly upcoming disease. Then he sees the facial expression. Amongst facial expression, he especially sees the tongue and the state of the tongue. Then the concomitant diseases, then the mentals, then the particulars. Then he also checks on the laterality of pneumonia, whether it is left upper, left lower, bilateral, right upper, right lower, etc. Although for some medicines he says they are particularly left-sided or right-sided, for some medicines he tells you that they may be left or right, they may be bilateral. So this is sometimes questionable, but laterality he always checks. Then he checks the type of cough, and then he does a differential drug diagnosis for you. So this is how Borland plans the examination of his pneumonia patient. Now, aconite, ferrum phos, belladonna, and ipecac for incipient stage. Now, what he means by incipient stages, that patient who come to you in the first 24 hours of catching influenza. And in aconite, there is a sudden dry, short cough, which is due to dryness in throat with acute stabbing pain on the left side of chest. Then in first 12 hours, you may also see some sign of pneumonia developing on the apex of the left lung. Here there comes a distinguishing point in aconite, that aconite patients with definite early involvement of the left side of the chest, and they are aggravated by lying on the affected side. Instead of being, you have to now differentiate aconite with ferrum phos. Now, ferrum phos and aconite have a very beautiful distinction. The roughness or dryness in the throat is indicative of aconite, but the roughness and dryness behind the sternum, that is in the trachea, is indicative of ferrum phos. Then there is one distinguishing point, that the coughing is many a times associated with the attack of epistaxis. Then the patients of ferrum phos are definitely chilly, they are sensitive to cold, and their cough is liable to be brought up by cold air. The time of aggravation of ferrum phos tends to be early in the morning, while time of aggravation of aconite comes to be late in the evening, sometimes up to the midnight. So here he is doing a differential diagnosis for you between ferrum phos and aconite. Another point that distinguishes ferrum phos from aconite is that right side of the chest is more likely to be involved than the left in ferrum phos. And you would always find some kind of pleurotic plane on the right side, right lower lobe, akin to bryonia pain that you might find later in the case if ferrum phos is not able to clear off pneumonia. Then with that pleuritic rub, you are liable to get the development of very sharp pleuritic pains which are aggravated by motion. Now this is typical of bryonia also, aggravated by motion. But bryonia has another distinguishing point wherein the patient is better by lying on the painful side. Now, belladonna. Now the belladonna attack is as acute as aconite, that is to be understood. The attack is very severe. The temperature shoots up sometimes to 103 to 105 degrees with a bright red face. And very often you would find a generalized blush on the face, especially on the cheeks. In children, you will find that. Now, in aconites, you would find extreme anxiety, a kind of a fear of death. The patient may predict the time of death. The patient may say that I'm going to die. But in belladonna, anxiety is replaced by excitement. The patient would be restless and excited and loquacious also, would be talking much. And then if you check the pupils are dilated. Now the belladonna mouth is always dry. Instead of that dryness, the patient is not very thirsty. But the patient may request you to have some kind of lemonade, which is indicative of belladonna very strongly. Now this is a comparison of belladonna tongue. Now the classic belladonna tongue is said to be strawberry tongue, which you are seeing on the left side of the screen. The tongue which is triangular and protruded out. Now strawberry tongue is a tongue which is diagnostic of a fever called as scarlet fever. It is also diagnostic of belladonna in a way. But in pneumonia, you would not find a classic strawberry tongue. What you would find instead is a tongue on the right side of the screen, and that would be congested, dry, dark, red tongue. This is a congested, dry, dark, red tongue. This would be a variant of what belladonna is normally seen, and belladonna tongue is normally seen, and what belladonna tongue you see while patient is having pneumonia. Now, mostly in belladonna, you have right side pneumonia, but it can be left side also. The cough is very dry, very painful, and it is a tearing type of cough. The cough is always associated with congestive throbbing headaches. The chest wall becomes astonishingly sensitive to touch and is horribly painful on coughing. So while the brainia patient is liable to hold his chest like this, but brainia patient is going to hold the right side of the chest, but the belladonna patient would not like even to touch the chest. Then the child usually is flushed, the skin is hot, sweaty, but mostly you would see a dry kind of a skin of the face, but the head would be very hot and sweaty. The temperature would be high. Now, the skin of belladonna would be dry. But when you are going to talk about ipecac, you would see the same kind of flush as you would see in belladonna. The patient would be hot, but the face would not be dry. The face would be sweaty. So it would be flushed. In ipecac, it would be sweaty and hot, and the temperature would be high. Now, ipecac, sometimes most of the people, ipecac is associated with either cough and vomiting or with vomiting and gastritis, etc. But ipecac is a very important remedy for acute coughs. And the acute cough of ipecac is similar to belladonna. So whenever you are suspecting a case to be belladonna, you must always have ipecac in your mind. Always in this ipecac children, the thing that strikes you most is the rails. There would be the rails. If you put the stethoscope on the chest, there would be generalized rails and rattling in the chest. This is what you are not going to find in belladonna, but this is what you are going to find in ipecac. In their pneumonia, these ipecac patients always have a good deal of nasal irritation. And one pretty striking symptom here is that all ipecac pneumonia patients have sneezing attacks. This is very, very important. Then in ipecac patients, usually you would find lobar pneumonia. And in a straight going lobar pneumonia, the ipecac tongue is clean. it is pink. But in bronchopneumonia, when the patient has developed bronchopneumonia and patient requires epicough, that is, patient is coughing and patient is sneezing and patient is hot and patient has face which is hot, flushed and sweaty, then you would find that the tongue is heavily coated. And as a rule, all the patients of epicough are thirstless. Now, this would cover all the remedies of incipient stage. I am going fast, I know, but you would always have this luxury of having this lecture on THA website, so you can go and visit it again and again. But I don't have the luxury of time right now, and I have to finish this, so that is why I'm going to do it fast. And now next is frankly developed pneumonia. The cases that you see after the first 24 hours, and commonly I must tell you, many cases that are going to tumble to you are going to be of this class, frankly developed pneumonia. So you must have these remedies on tips: Bryennia, Phosphorus, Veratrum viridi, and Chalidonia. Now, Bryennia, before going into the materia medica of Bryennia, etc., let me tell you how Borland used to prescribe and how we do prescribe here. And many of my students who have learned homeopathy in this place with me and my father are now high potency prescribers, and they are doing very, very well. So to the beginners, I would say, don't be harassed by what I'm going to tell you right now. High potencies do not kill. Wrong medicines may kill, wrong diagnosis may kill. High potencies do not kill. They can cure provided you know them how to use it and you are confident enough to use it. So let me tell you what Borland has written. I am convinced that where the prescribing is accurate, the best results are obtained by the use of very high potencies. I should say that in my own practice, that is in Borland's practice, in the average case, I would prescribe a 10 Though where the indications were very clear, my preference would always be to go higher provided there were no contraindications. Now, there are certain contraindications for which high potency should not be prescribed. Then he says, I give CM in preference to 10M if I'm perfectly certain that I have the right drug. And I must tell you that all great prescribers have doubts in their mind when they are prescribing their medicines. I have seen all great prescribers always checking and rechecking their materia medica before prescribing, because they have so many differentials in their mind. They are many a times not very sure. So he says, when I'm perfectly sure, I give CM. If I am a little in doubt, I give 10M. Then as regards repetition, watching the results again, an average case of frankly developed pneumonia. Now see the confidence of Borland. He says that an average case of frankly developed pneumonia will require at least 6 doses of the medicine. It may require more. So in practice, what one dose is in order, 6 doses of whatever potency one chooses, in the average case probably at 10M, and have it repeated every 2 hours, which means that if you have chosen Bryennia for somebody, then give 6 doses of Bryennia every 2 hourly in whatever dose. I prefer to use 10 drops 2 hourly, 10M. If the patient is serious, then it is 1 hourly. If the patient is very serious, it is half hourly. So this is how I do it. Then coming to Bryennia. Now, Bryennia patients are congested, heavy looking, sleepy looking patients, but they are irritable too. they are short-tempered, and they are difficult to satisfy. Their skin is hot and damp. Now, there is no dryness here. Now, apart from their cough and chest symptoms and pneumonia symptoms, there are certain things that are very, very diagnostic of bryonia. One of them is that they always have a headache when they sit up while rising from a bed. They have a headache when they sit up from lying from a bed or when they rise up from a bed. They feel extremely ill on sitting up. That means they feel giddy and sometimes they feel faint. That is postural hypotension is something that they feel. This is very diagnostic of bryonia, along with the typical bryonia thirst and the bryonia modality of having pains aggravated by motion and being better by lying on the painful side. Now, in bryonia pneumonias, you will always find a thick white coating on a dry tongue. The mouth feels dry. The patient is very thirsty. There is always a bitter taste in mouth, and the main desire is for large quantities of cold water. If the disease is more extensive, you find the right lung involved to a greater degree than the left. So do not say, never say that if it is a left side pneumonia, it cannot be bryonia. Although with left side of pneumonia, you can see, you can think of another remedy, and that is I will tell you the name of the remedy, but that is another remedy. In the meanwhile, bryonia is a remedy which is mostly on the right side. You would find the patient holding his chest on the right side, lying on the right side, and coughing. With pleuropneumonia, there would be sharp, intense pleuritic pain. That is why the patient is holding the chest and lying on the painful side. It is then that you see that the bryonia picture of the patient sitting up in the bed, trying to hold the chest with the hands to keep it quiet while he is coughing, or lying in the bed, trying to hold his chest while he is coughing. Usually in these bryonia pneumonias, there is a certain amount of irritation in the throat. The patient mostly have a rather hoarse throat. They feel hot. They are uncomfortable in a hot atmosphere. Now coming to phosphorus. Now in comparison to bryonia, you must always remember phosphorus. And as a rule, phosphorus pneumonia develops more quickly than bryonia. This is something which is very important. That is why we had chosen, while we were choosing our genus epidemicus, we have chosen phosphorus over bryonia. Now, though the patients are obviously tired, they do not give you the same impression of sleepiness as bryonias do. They are more awake, and they are more worried, and they are more anxious. They are very apprehensive. They do not want to be let alone. They want somebody around. They are afraid of dark. On seeing these patients, you are immediately impressed by the fact that their respiration is seriously imbalanced. Next, you notice that the patients tend to be tremulous. They are shaky. Now, this is not kind of a spasm, but a kind of a twitch. They are having tremors related to anxiety, twitches relating to anxiety. Fobister has described very well a phosphorus child. Phosphorus child is an alert child, similar to a bird sitting on a wire. Now, very early in the disease, there are signs of the accessory respiratory mechanism coming into play. That means there is dyspnea very early in the disease. The chest wall heaves a bit. There is flapping of LNSI, and the accessory muscles of the neck are also moving, and the patient is obviously having difficulty in breathing. Always in this phosphorus pneumonia, there is very trying, tormenting, irritating cough. It is called a shaking cough. The whole body shakes along with cough. And the cough is often accompanied by a feeling of rawness or burning in the chest. Phosphorus patients, no matter what their ailments, they always want to have cold drink. But in pneumonia, with their very dry mouth, they very often ask for something juicy or sour rather than plain cold water. Here you would see that they are similar to belladonna, but belladonna is thirstless and yet would like some lemonade, while phosphorus is thirsty and would like lemonade and would drink lemonade in glasses. So large amount of sour drinks or cold drinks frequently is phosphorus. They want to be propped up, which is not surprising when you consider the feeling of oppression in the chest. But in addition to that, you often see them with the chin tilted up and the head thrown well back. Now, this is a typical position of phosphorus late in pneumonia. You would see the patient like this. The head would be tilted up and the chin would be up and the head is thrown back. This is a typical position of late phosphorus pneumonia. Another point is that the patients are chilly patients. They feel the cold, and dry draught of the cold air is liable to excite an attack of coughing. Remember, bryonia is hot, phosphorus is cold. Phosphorus patients very much dislike being left alone. This is typical of phosphorus. This is also typical of lycopodium, but because of a different reason. In the phosphorus patient, in the earlier stages, there is very tormenting dry cough with very little sputum indeed. But about the third day, that sputum tends to increase and there is a rather bright red streak. Now, this is a stage of red hepatization. By this time, there is rather bright red streak through the mucus sputum. By the fourth day, that red streak through the sputum becomes darker, and very soon afterward, you have that typical rusty sputum of phosphorus. Now then, there are certain fine differences which are not very important. We come back to another remedy, that is Virata viridi. Now here, the hallmark is pulsations. Virata viridi patient always complains of feeling of intense pulsation. The pulse is full and bounding and the BP is always high. The patient's face is bloated and swollen looking. There you also have a kind of excitement like belladonna. The patient may develop a violent delirium like belladonna quite early, and the patients are liable to have all sorts of obsession that they see faces and figures on the wall similar to belladonna. And like belladonna, you are going to always find widely dilated pupils. So how to differentiate between belladonna and Virata viridi? Now, belladonna has an intense flush and a burning dry skin, whereas Virata viridi is livid. It is not as bright, but has a bluish tinge. But you might miss that, but you would never miss that the skin is covered with beads of sweat, and it is like this. Here you have belladonna, typical dry skin with flushed face, and here you have Virata viridi, wherein you have beads on the forehead. You can see the beads of sweat and flushed face. So this is the difference between belladonna and Virata viridi. In spite of the high temperature, you would find profuse perspiration. Patients are intensely thirsty, and the patient complains many a times that everything that they take is tasting sweet. Now this is striking, singular, uncommon and peculiar symptom. Then there are two types of tongue in veratrum viridi. We all know the classic tongue of veratrum viridi, which is there is a thick coating and a bright red streak down the center. But there is another tongue of veratrum viridi, which is thick yellowish coating. And this is not uncommon. This is also commonly seen. So if you have a pneumonia with a high temperature, full bounding pulse, generalized sweat, thirst, and that red streak down the center of the tongue, you need not bother your head any further. This is veratrum viridi and will clear up the case every time. Then chelidonium. Now, many a time chelidonium is missed, and Borland has written so. I think most of the pneumonias in which you give bryonia without success are cases in which you have missed chelidonium. Now, there are certain differences. The outstanding distinction between bryonia and chelidonium is that bryonia has an intense thirst for cold drinks, but chelidonium has a desire for hot drinks. So next time when you are taking a case and giving bryonia, do ask the thirst for cold drinks and thirst for hot drinks. If it is thirst for hot drinks, think of chelidonium, provided all the other symptoms match, because chelidonium also has two marked period of aggravation, and one is about 4 o'clock in the afternoon, and the other point of aggravation is 4 o'clock in the morning. My personal observation is that lycopodium has a marked aggravation in 4 o'clock in the afternoon, and chelidonium has a marked aggravation at 4 o'clock in the morning. So chelidonium has double periodicity. Now we come to group 3, the complicated pneumonias. Now, this is a more difficult problem, complicated pneumonia. Complicated either by the fact that the patient has mixed infection or by the fact that he is a very unhealthy patient to start with. Secondly, there is a creeping type of pneumonia or the frank bronchopneumonia that creeps up. It used to creep up slowly, but with COVID-19, it doesn't creep up, it shoots up. So there are the types of cases that are much difficult to handle, and this is true. It is more difficult to decide what your dosage should be and what your reputation should be. And it is the type of case which seldom responds to one prescription, the complicated pneumonia. Same with the late pneumonias. Mostly your first drug improves matters and the patient becomes very much better. Then the symptoms change and you have to give a second prescription to clear up the case. When you are getting on to the later stages of pneumonia, it is little difficult to choose your right potency. Suppose you are called into a pneumonia that has been running 5, 6 or 7 days and the patient is obviously flagging. It requires considerable amount of judgment to give the right potency, because if you give too high, to which they cannot respond, and so we do them harm. On the other hand, you can miss the chance of cleaning up the whole thing by giving too low and not setting on an enough response. It is certainly difficult to choose the right potency for these cases. In a certain type of mixed infection, mixed influenza, pneumococcal infection, I think there is a grave danger in giving too high a potency. It is difficult to find a happy medium. In some of these bad cases, if you give too high a potency, you kill the patient. If the potency is too low, patients do not respond. This variation is seen in different patients even in the same epidemic. About 100 years ago, what they found in America was that the best potency was in 1M. Now, this is the time when Kent was ruling, and post-Kent, Margaret Taylor, Borland, and Kentians were ruling America, and antibiotics have not yet come in. So they found the best potency was 1M, which seemed to be high but not dangerous. And eventually they always gave a 1M in these severe cases with very good results. We in India are somehow, very afraid of giving 1M. At least I am not, my students are not, and we commonly give 1M. So in practice, what Borland has done, and I'm quoting Borland. So in practice, what I have done, what I have come to is that in these unpleasant mixed infections, I tend to give a 1M rather than 10M because it seems to produce less disturbance and yet produce a very definite reaction. And I repeat at about the same interval as for an ordinary straight pneumonia, that is every 2 hours. Taking the ordinary case, now we come to the medicines of group 3A, that is the low muttering kind of cases, the patients who are low. Now, the first medicine that we are going to talk about is baptisia. The onset is slow. Then you see how in a mixed kind of pneumonia, what he has classified is that group 3A, this is hot, congested, muttering type of pneumonias, wherein baptisia, pyrogen, laches, and Mark-Sol is required. While then there are definitely chili types, Hippersulf and Rustox. And then there is group 3B, wherein he has talked about bronchopneumonia, wherein natrum sulf, pulsatilla, senega, and lobelia are indicated. So let us first talk about the slowly growing pneumonia of baptisia. So its onset is slow. The first outstanding characteristic is befogged mental confusion. The state of the patient is befogged. The patient, you can see what the befogged condition means. This is the kind of patient that you would see who may require baptisia. The patients are dull mentally. Their speech is rather slow. There is a gentle wandering delirium. You wake them, they answer you, then they go back to this drowsy condition. They are drowsy. Their answers are, when you wake them, their answers are mostly incomplete. The baptisia patients are always cyanosed. Now they are cyanosed, which means their SpO2 is below 92. So they are cyanosed. They have a puffy cyanotic appearance. Their eyes look heavy, usually half closed. Their lips are cyanosed, and baptisia mouth is diagnostic of the medicine. Lips are cyanosed. There is a lot of sores about the mouth. The mouth itself is always very offensive and very, very dry indeed. The tongue usually has a brown coat down the center. It may be yellow to begin with, but it is usually very rapidly becomes brown. The tongue itself is dry to touch. There is intense dryness of the tongue. You do not get excessive thirst in baptisia case. Now, in this slide, you would see on the right side, this is the brown coating. This comes later. First, you have this yellowish kind of a tongue. It becomes brown coated and dry later on. You can see the dry papillae here. Then in this child, you can see the sore days. These are sores on the lips and the mouth, you can see this white kind of lining. This is called as sores. So you will see sores. The skin of bacteria patient is hot and damp. They have damp sweat, which is always having a very unpleasant odor. The main feeling of bacteria, the main complaint is a feeling of intense oppression in the chest. And with this sensation, they are rather afraid to lie down because lying seems to increase it and makes them feel as if they are going to suffocate. Very often they will tell you that the feeling of compression is not so much a sensation of chest wall being. There are two kinds of oppression that the patient may feel. One is that the chest is getting compressed from outside. But in bacteria, you don't have this typical compression of the chest as if a band is on the chest. Instead, you feel, the bacteria patient, they would feel that their lungs are being compressed. The lungs are being crushed inside. That is why they feel this kind of oppression. Another characteristic is that they have very scanty sputum. Now, the appearance of bacteria patient is like a toxic Bryannia patient. So I would say a patient whom you have given ferrum phos has not cleared up completely, may require Bryannia. After Bryannia has not recovered completely, may require baptisia. And if you want a Bryannia patient not to be converted into baptisia, then my experience is that you give them intercurrent. After Bryannia is failing and you see that the rails are increasing in the chest, the pneumonia is increasing in the chest, stop Bryannia and give tuberculinum aviaire. The patient is not going to land up into the state of baptisia. This is what we have observed. I have observed on my clinics and on my patients. Next, coming to pyrogen. Now, pyrogen is a lovely remedy for septicemias. Pyrogen is a lovely remedy for pneumonia, which has infection, mixed infection of several bacteria or fungus or whatever. The onset of disease in pyrogen is more rapid than baptisia. Instead of a dull patient, you would find a hot, muttering patient. It would be a loquacious patient. The patient would be impatient, would talk very fast. They can talk a good deal, and they are liable to be a bit irritable. The temperature is definitely very, very high in pyrogen, about 104 to 105 degree. And fever is always accompanied by considerable hot sweat. Now the patient would say that patient is chilly, but the patient would be having hot sweat. This is something to be understood, and it is very important regarding pyrogen. The tongue in pyrogen and bacteria cases is sometimes very difficult to distinguish, so we are not going to talk much about it. It is similar to baptisia. Both these patients, both baptisia and pyrogen, suffer from waves of heat. They would be having waves of heat. But what differentiates baptisia from pyrogen is that pyrogen has waves of shivering also. So there is alternating waves of heat and waves of cold. So hot flushes and cold flushes. This is very important, but the main there is another similarity between pyrogen and baptisia, that is general soreness of the body. The body is generally sore like rustox, and that makes them restless. And they would also give you the same kind of delusional description of not knowing where their arms and legs are. And they both say that they are moving about in order to bring their sensation back to normal. That is, they are trying to bring their hands and arms and legs together. You cannot distinguish bacteria and pyrogen on this respect. But there is one point in pyrogen which no other medicine in materia medica has, and that is the discrepancy between the pulse and the temperature. The discrepancy may be very rapid pulse with a comparatively low temperature, or equally common, it may be a very high temperature with a comparatively slow pulse. Now, this is something that has to be present when you are prescribing pyrogen. Then coming to lachases. Now we all have a great, picture of lachases in our mind. That the lachases patients are loquacious. They are, they talk too much. They are sly and this and that. But in pneumonias, especially when you are having a complicated pneumonia, and if the patient is requiring lachases, mind you, the patient would be similar to bacteria and pyrogen. Then you would have to acquire an entirely fresh picture of lachases from the one you associated with lachases in the chronic patients. And the picture is this. You know that they are extremely loquacious, but in pneumonia, where lachases is indicated, you are much more likely to get the extremely toxic, drunken, confused, tearful, sentimental sort of patient, similar to pulsatilla. Now they are heavy looking, like this lady on the screen on the left side. They are heavy looking with a mottled cyanotic appearance, very puffy looking face, puffy swollen looking cyanotic lips. The lips are cyanotic and puffy. Their speech is thick. They stumble over what they are saying, and they frequently leave their sentence half finished, like bacteria and pyrogen. Then they have delusions. They hear voices. They imagine all sorts of things. They become suspicious. They think they are being poisoned, and they sometimes refuse to take the medicine. Do not confuse here lachases with hyoscyamus. As far as the appearance of the tongue is concerned, it is very, very dry, swollen, dark red tongue. And in spite of that dry tongue, you will get a good deal of very sticky, stringy saliva in the mouth. Now, whenever you have salivation in the mouth, mostly people think of Merxol. But two remedies must always be thought about along with Merxol. There should be lachases and lycopodium. Now, these lachases patients, they hate to go to sleep because of this sense of suffocation that they have. And if they do drowse, they are almost certain to wake up with a sense of suffocation and a most distressing attack of coughing. These patients mostly get a very violent surging headache with their cough. It feels as if all the blood in their body is forced into their head becomes hot, and their feet and hands, they become cold, similar to belladonna. Then there are two very special symptoms of lachases pneumonia. One is that with their respiratory distress, these patients always have a horrible choking sensation, a feeling of tightness around their throat, and they cannot bear to have the blankets up around their neck or anything tight around their neck, as they feel they would strangle, and if they had anything tight around their neck. The other characteristic symptom is that they have acute stabbing pain in the chest, very often on the left side, and they cannot bear any kind of pressure on those sore chest walls. This would distinguish lachases from many, many medicines. The patients feel the classic lump in their chest, not in laches pneumonia, they would not feel the lump in the throat. They would feel the lump in the chest, and it is as if it could shift to a certain distance. But when it would kind of be a chest either on the left, mostly on the left side, it would shift and then it would get stuck. You can always hear the rattle in the chest, and yet the patient cannot expel anything. The cough is very difficult the sputum is very difficult to expel. Now the look on the patient's face is sometimes not teary and weepy and sentimental, as I have told you. It can be muddled, besotted. A besotted look of the patient is a look that I have drawn your attention to. This is occasionally a look that you would see in a patient of lachesis pneumonia. Now, these patients who are not, who are having pneumonia and who are not the classic chronic lachesis type, these pneumonia patients, they develop hyperesthesia. They may develop this acute, hyperesthesia to noise, to light, and to smell. Then coming to Merck. And you must always, have a differential of lachesis, Merck and lycopodium in your mind whenever you are prescribing one of these three medicines. Now in Merck pneumonia, it is very difficult to distinguish between the mentality of lachesis and mentality of Merck. Like the lachesis patient, the mercury patient, the Merck patient tends to have a very puffy face, but it is rather more livid in color. It is little more sweaty. The skin looks a little more greasy, but you cannot differentiate this little more. As regard mentality, the delirium gets very early in mercury patients, in Merck patients than in lachesis patients, and they are as suspicious as lachesis. Their speech is as difficult as lachesis, but in lachesis you would find that the patient is going to stop speaking halfway through, while in Merck you would find a kind of stammering while the patient is speaking. The next thing which helps you in differentiation between Merck and other remedy is that the Merck patient has a very marked generalized tremor of the hands, of the tongue, and of the facial muscles. Lachesis have a tremor of the tongue, but do not have the tremor of the hands and of the facial muscles. But Merck has a very pronounced tremor of the hand and facial muscles along with the tremor of the tongue. Then with Merck mouth, you would see a tendency to ulcerate, the tendency of ulceration in the corners of the mouth. Then very watery, profuse salivation. It is not as stringy as lachesis. You would find definite abscess patches in the mouth. And these patches, they would be burning. The ulcers would be burning. Now, this is a typical Merck tongue. You can see the indentations on the margin of the tongue. Then mercury is a rather swollen, flabby, pale, greasy looking tongue. The patient usually complains of an unpleasant, sweetish, offensive taste. In these mercury patients, there is always a pretty profuse, generalized sweat. And as a rule, in mercury patients, there is a swinging in temperature. And it is biphasic, and you can link on to the general mercury instability to heat. They are either far too hot or far too cold. While the lachesis patients are always hot, they cannot stand heat. The cough of Merck patient tends to be rather different. It is usually a dry, racking cough, and here you will very frequently get a typical mercury indication. Now, this is very, very, very diagnostic of Merck, that the cough tends to come in double paroxysm. The patient has a violent paroxysm, then there is a pause, and then another paroxysm, and then a period of peace. So it is and then it is over. So this is typical of Merksol. Another distinction is that as a rule, you get your main involvement in the right side of the mercury rather than on the left side in the laches. Laches has a feeling of chest being full, as if the chest is being full, there is a lump in the chest, while Merksol, they have a feeling that the chest is going to burst open. Then the sputum of Merksol is always offensive. So while discussing these complicated pneumonias, you will notice that Borland has taken hot, congested, muttering type together, and then he has taken two definitely chilly remedies in the end. They are Hipersulf and Rustox. Now, as a rule, Hipersulf patients are pale in appearance, although they may have a somewhat hectic flush. They may cough, their face become flushed, and then again it becomes pale. Hipersulf is always chilly and extremely sensitive to cold. Your hyper patients are very chilly. They want their blankets right up to their necks. They want their room as hot as they can have it. They hate to have any draught in their neighborhood at all. They are difficult patients. They are horrible. They are discontented. They are dissatisfied, and they always have a critical outlook. They would always criticize you. Mind you, it is similar to Chamomilla kind of or Lycopodium kind of patient. These hyper patients are definitely oversensitive. They are disturbed by their surroundings. Their speech is always hasty, and it is usually a complaint of some kind that they have to talk about. Now, their facial sometimes their face of Hipersulf is diagnostic. They tend to develop a definitive labial herpetic eruption or some kind of eruption or a crack at the corner of mouth. The upper lip tends to be rather swollen and thickened and very often reddened. And often in hyperpneumonias, there is a deep split in the center of the lower lip, which we commonly associate with natrum mute. But here, in hyperpneumonias, you would see a deep split in the lower lip, which, along with the eruption that you might find on the corner of the mouth, may indicate Hipersulf if the patient is chilly. Now, they also complain of a tongue which is hot and burning. And oftenly, there is a burning hot tip of the tongue. And these patients have two main physical complaints. One is a sense of extreme weakness in their chest. The other is which is much more common, that is acute stabbing pain in the chest. And these pains are accompanied by a definite aggravation from lying on the affected side, which is opposite to bryonia. Stabbing pains are aggravated by lying on the affected side. Now, as regard to the cough of the Hepar case is choking, strangling, spasmodic cough. It comes in frequent paroxysms and is accompanied by dyspnea. In these paroxysms, you will find the patient sitting up in the bed with the head tilted well back, and in their pneumonia, the cough is accompanied by a very profuse, usually purulent, blood-stained sputum. It is yellow and blood-stained. All the discharges of Hipersulf are purulent, yellow. They are thin, mostly thin and yellow, and they are offensive. And the temperature of Hepar cases is rather swinging, septic time of patient, with the patient being chilly. It is always accompanied by profuse sweating, and in spite of the sweating, there is not a definite drop of temperature, and the patient feels, if anything, more by the sweating, the patient feels uncomfortable and doesn't feel comfortable. Any slight effort on the patient's part will produce one of these violent sweats. These hyper patients always feel very much worse after they have gone to sleep. So they are worse by perspiration. They are worse by going to sleep. You expect your hyperself pneumonia patients to wake up feeling better. You expect your pneumonia patients to wake up feeling better after a decent sleep. But in hyperself, it is opposite. The sleep is unrestful and they have very distressing dreams. They often have dreams of fire, and when they wake up, they have a definite aggravation. And there are two times of aggravation in hyperself. One is 6 to 7 o'clock in the evening, and another is about 2 o'clock in the morning. And they are liable to become very exhausted by this bout of coughing, and they may settle down afterwards and fall asleep. When they wake up, they cough, they get exhausted, then they go to sleep, and then they again wake up into aggravation. This is how the cycle goes. Then we come to rust tox, the other chilly remedy in mixed infection pneumonias. Now, rust tox develops a bit slowly than hyperself. The lips are very cyanotic, and extensive herpetic eruptions may also develop quite early in the disease. It can also be a rash. In their pneumonic attacks, rust patients are horribly distressed, they are depressed, and they are discouraged. The patients later on may become mildly delirious. It is a low, restless, muttering delirium, like in baptisia, and it is always accompanied by extreme physical restlessness as well, like in baptisia, because of the soreness of the body or the pain of the body. They have aching pains, but the difference here is that rust tox, the aching pains are better by movement. So this general restlessness, pain, aches, they are always better by movement. Now this is typical rust tox tongue. You have a typical red triangular tip, then the margins of the tongue are red, and then there is a coating. This is a white coated tongue with red margin or a red triangular tip. Now this is in the earlier stage, before the patient becomes delirious. In the earlier stages of rust tox pneumonia, you would find this kind of tongue. Once the patient gets delirious, you are going to find this kind of tongue. Now this tongue is brown and it is intensely dry, and you can see the papillas, they are dry and papillas, they are hairy kind of appearance. This is because the papillas have become dry and they are brown. Now the patient always complains of a metallic sort of taste. The mouth and throat are appallingly dry, as if they are burnt, and they have thirst, and they have a preference for cold drinks. The cough of rust tox is a tormenting cough. The patient will usually tell you that they have a feeling of intense irritation in the middle of the chest, somewhere behind the sternum. The rust patient is just as about sensitive to cold as hyper patients. There is always a certain amount of laryngeal involvement in these rust cases, and it may be troublesome indeed. The temperature is again swinging tight. Then there are 2 points that distinguish rust from other medicines. One is that after a paroxysm of coughing, when the patient has apparently got very hot, he immediately gets a horrible chilly sensation. Then he sweats profusely, feels horribly cold, and wants to be covered up. The other point is, if they drink too much of cold water, which they want to drink, they are apt to feel very chilly. and it is very likely to precipitate another paroxysm of coughing. So they want to drink cold water, but cold water causes them chilliness, and cold water also precipitates coughing. This is very typical of rust talks. As a rule, in these rust cases, the times of maximum aggravation occur during the night rather than during the day. The patient becomes more restless, more worried, and more inclined to go out of bed during the night. So this completes our mixed pneumonia. Now coming to the bronchopneumonia that you are going to see so typically in COVID-19. The medicines are natrum sulph, pulsatilla, Seneca, lobelia. Pulsatilla and lobelia are two medicines which are coming up quite frequently in this COVID-19 acute bronchopneumonia cases. Seneca is also coming up quite frequently. Now, these type of unpleasant cases that start as frank lobar pneumonia, and probably 24 hours later a patch appears somewhere in the uninvolved lung, and the next day there is another patch somewhere else, possibly without much clearing up of the old area. That is the type of case in which these drugs are indicated, and I think you can cover pretty well with the 4 medicines that Borland has told us. On particular indications, you may require any of these drugs that Borland has described, but more likely, you may need any of the other drugs that have been discussed previously, but more likely pulsatilla, natrum sulph, Seneca, and lobelia would be indicated. Now coming to natrum sulph, the patients are usually definitely cyanotic, and there may even be a definite jaundice. Now, natrum sulph is a premier remedy for hospital-acquired pneumonia. The patient is usually depressed, both mentally and immunity-wise. The patient is irritable, sensitive to noise, sensitive to heat. They have a hot, sticky skin surface. Their tongue is typical. It is a grayish-green tongue. This is characteristic of natrum sulph. Sometimes it may also have a yellowish tinge, but grayish-green is typical of natrum sulph. Then the patients always complain with the cough, a stabbing pain in the chest wall. Now this is aggravated by coughing. And while coughing, you will find these natrum sulph patients sitting up, supporting the side of the chest to keep it as quiet as possible, just like bryonia patients. Now, there is physical restlessness, but this movement that they try to make, this aggravates their symptoms and does not give relief. One characteristic combination of natrum sulph is very important. The pneumonia is accompanied with occipital headache. As in epicoc, pneumonia is accompanied by bouts of sneezing. In natrum sulph, pneumonias are accompanied by occipital headache with bitter taste in mouth. Then there is intense heat in the legs, and from the legs, from knees, this heat travels downwards. The sputum is definitely greenish. The ordinary natrum sulph time of activation is about 5 o'clock in the morning. But in their pneumonias, mind you, in their pneumonias, this is not the time of maximum activation. It is much earlier, between 3 to 4 o'clock in the morning. Then coming to pulsatilla. Now, in pulsatilla, usually you would get a history of patient having a frank cold, a catarrhal condition, which has spread down into the chest. The appearance of pulsatilla patient is dusky red, kind of puffy, bloated person. They become definitely anxious about themselves, worried, afraid that they are not going to get better, and they very definitely hate being left alone. They want somebody about And they always want affection. They always want to be consoled. In the pneumonia, pulsatilla patients get very marked dyspnea. It is very, very extreme. It is accompanied by a feeling of intense tightness of chest or a feeling of horrible fullness of the chest with a very acute air hunger. They want to have the doors and windows open, and they love a draught of air. So they would want the doors and windows to be open. They would not want the room to be crowded, and they would like, air to flow in the room. They have a pretty violent gagging, choking cough, and in their paroxysm of coughing, they are liable to become acutely cyanosed. It's kind of a blue bloater. If you can understand, in cases of emphysema, you see blue bloaters. So it's kind of blue bloaters. Quite frequently, you will get the statement by these pulsatilla patients that after one of these violent choking cough, it feels as if something were to loose in the chest and the whole chest felt raw. It is kind of a lining has broken loose in the chest and the chest has become raw. This is the kind of statement that you get very often in pulsatilla. Then their mouth is dry. Some mouth and throat, they are extremely dry, yet the patient is not thirsty. As regards their position, these patients are rather more uncomfortable lying on the side, which is mainly involved. Their most comfortable position is lying on the back, propped up a bit, and particularly with the arm raised out from the side. It is like this. It is like this. This is a typical posture of pulsatilla while they are having dyspnea. All these pulsatilla patients are, of course, sensitive to heat. They often complain of a feeling of generalized hotness. This typical symptom of putting their feet out of the quilt can be seen in pulsatilla very often, in pulsatilla pneumonia also. The sputum of pulsatilla is always very difficult to expectorate. It is tenacious, and the patient almost chokes in the effort to expel it. Then coming to the third of these medicines, and that is Seneca. Now, this is a lesser known remedy, but I have been using it quite frequently. Although I use Seneca mostly in lower potencies, in 2x to 3x potencies, but it has very important use. And according to Borland, there is rather more bronchitis surrounding the patch of consolidation than there is in the two previous drugs. And I agree. I find Seneca to be a very good remedy for COPD, especially in the aged and children, wherein the cough is not easily expelled and there is dyspnea. And maybe sometimes consolidation comes up. In other words, there are more rails, coarse rails, which are pretty generalized in the chest, and amongst them you will pick up definite patches of consolidation. And most of those I have seen have given me the impression that I have had once seen the earlier, they would have probably have been bryonia. So once bryonia fails, a misbryonia might quite well run into a Seneca. It may become toxic like bacteria. It may become, turn into a Seneca. In appearance, the Seneca patients are very flushed. They have a hot, sweaty skin. They always have a very intense respiratory embarrassment. This is very important. There is a feeling of intense oppression in the chest. It feels as if it has a ton of weight sitting on the chest and they just cannot breathe. It is a load on the chest. The Seneca cough is troublesome. It is practically constant, violent cough, and it produces a strange sort of hyperesthesia on the walls of the chest. With the paroxysm of coughing, they become frightfully hot very red in the face and covered with a hot sweat. And with this profuse sweating, there is apt to be a good deal of pseudomonas rash. There becomes a rash. There comes a rash in their body. Mostly in the pneumonias, there is a certain amount of hoarseness, which is very true. Borland says every Seneca case I have ever seen has had peculiarly loud, harsh breathing with their respiratory distress, which means there is an element of COPD, bronchitis. There is liable to be a certain amount of cyanosis of the extremities. The patient frequently have a very high temperature. They are liable to develop signs of failing heart. Now, this is important. They are likely to develop signs of failing heart early in the disease. The right side of the heart begins to dilate, and a definite generalized edema of the lung is very likely to develop. Now, this again leads us to COVID-19, where you find if the D dimer is raised, that the patient, and the LDH is raised, that the patient has this predilection of having some kind of heart involvement. And recently with COVID-19, what I've been seeing in my clinic is acute coronary syndrome, ACS, developing within 3 weeks of having COVID-19. So you have to be prepared. You can help these patients too. Then coming to Lobelia. Now, Lobelia has been a wonder drug for me in this epidemic of COVID-19. You will find that, but for Borland, what Borland has written is that you will find that Lobelia is not very often indicated. It was not in his time, but it is now. It does cover a very definite picture, and it has 1 or 2 very striking symptoms which I think are not covered by any other drug. Now, Lobelia patients look very ill. They are rather pale and they have sweaty skin. They have a horrible oppression and of a very marked sense of fullness in the chest, which they say they can't shift at all. They just cannot move their chest. They have spasmodic dry cough, and the cough is always attended by nausea. Now, herein, this stands as the front ranker, more important than your epicock. Spasmodic dry cough attended by nausea. They want to keep still as they possibly can, as still as they can, and any movement, any exertion may increase their sense of respiratory embarrassment and also the nausea. This is important. Nausea is also increased by movement. Then this nausea is accompanied by salivation. And there is one definite characteristic about the Lobelia nausea, that it is very greatly relieved by eating or drinking. This is opposite. Mostly people who are having nausea, they don't want to eat or drink. But in Lobelia nausea, there is salivation and the patient wants to eat and wants to have something to drink because it relieves nausea. And then there is a very distressing feeling of emptiness in the epigastrium. You would also find a rash, a kind of intensely irritating urticarial patch on the skin. Then a localized edema on the chest wall can also be seen, although I have not yet seen a localized edema on the chest wall of any of my Lobelia patients. With coughing, they are liable to develop localized patches of ecchymosis, which is common because they might be having septicemia or decreased platelet count. Pneumonia attacks. There is one other Lobelia symptom which sometimes crops up, and that is that in these pneumonia attacks, the patients quite frequently complain of very violent sacral pains. I have not yet seen these patient has complained about sacral pain. Now coming to the late pneumonia, and this would be the last part of Borland's study of pneumonia. We now come to the consideration of drugs for the later stages of pneumonia. Now, this is moderate to severe or severe to critical type of pneumonia. while we were staging pneumonias, COVID pneumonias, COVID illness, it was late pneumonias are going to crop up in moderate to severe or severe to critical COVID illness. A pneumonia you have not seen in the earlier stages, or it is one of your own case that is not resolving well and not clearing up satisfactorily, and the SpO2 is going down and the patches are increasing. The consolidation is increasing. For these type of late pneumonias, you can cover them well with 6 of these medicines: antimonium tart, carbovec, kalicar, arsenic album, lycopodium, and sulfur. Let us quickly go through them, but before that, listen to the confidence of Borland, the doctor. He tells you that when I have covered these drugs, which means all the drugs along with these 6 drugs, when I have covered these drugs, you ought to be quite prepared to go and tackle a pneumonia epidemic and expect to get 100% recovery. And I must tell you that about 180 cases that I have seen of COVID-19, I have had 100% case recovery. None of the patient has died or gone to the ICU. Sometimes by choice they have gone to the hospital but never gone to the ICU. I think the best way to take up these drugs is in the order, which means the drugs of late pneumonia is in the order in which Borland is giving it to me. In the adults, you expect to find the symptoms of antimony tart cropping up in late in pneumonia. You do not usually get them in early stages, and by the time the patient has gone to an antimonium tart state, mind you, the patient is seriously ill. Sorry. Now, the appearance of the patient is very suggestive. They are pale. They have a pinched look. Now, in this slide, in the photograph, you can compare the pinched look with the normal look with the ballooned look. So they have pinched look, rather bluish discoloration of the skin because of cyanosis, and they are covered with cold sweat. Now this is a better lithograph of pinched look. The nose looks rather pointed, pinched in, and very often it has a somewhat sooty color. The LNSI are flapping with exertion of the accessory muscle of the respiration of the neck, which means there is heavy respiratory distress. The lips in typical antimonium tart cases are rather livid, which means they are dark blue-gray like a bruise. Livid means dark blue-gray like a bruise, and they are usually very dry. The impression that you get of these patients is of extreme suffering. They are intensely distressed to be left alone, and you often find them lying panting or for breath and moaning. As a rule, there is a very thick coating to the tongue. It is pasty, white coating, and the tongue looks just as if it has been painted with white enamel, as you can see in the photograph. The outstanding point is that, in spite of the dryness of lips and tongue, antimonium tart patients are completely thirstless. There is loathing of any kind of food, and there is acute intolerance of milk. There is a very rattling cough, and yet, in spite of the rattle, there is very little sputum expelled because the patient is exhausted and the muscles of the chest are exhausted. With their violent cough, the patients suffer from a great sense of oppression in the chest, and very often there is a great soreness of the chest wall with nausea. they have acute air hunger, and a warm room makes them very much more uncomfortable. With extensive chest involvement, the hands and fingers, feet, and lower extremities are liable to become cyanotic. This is peripheral cyanosis. The patients become, which means respiratory cyanosis. The patients become very tremulous, and in spite of their general heat and aggravation from warmth, they very often complain of a feeling of coldness from about their knees downward. These patients, they just cannot lie down flat. There is always a tendency for heart failures. The circulation is giving out, the pulse tends to become irregular, the heart tends to dilate. Well, that is the kind of case that we meet here from about the 5th day of the disease onwards. Now see, nowadays we are being told in COVID-19, 5th day is very important. Borland has told us before, about 100 years before, that 5th day of the disease is important because these late pneumonias, they are met in the 5th days when things start to fail. We quite frequently see patients coming in that state. We do not expect a patient ever to get into that state once he is in the hospital. This is the confidence of Borland. He doesn't want his patient to be in this state if homeopathy is given. But if they are so, then we have to tackle them. Then from antimonium tart, we turn over to carboveg. It is the same kind of serious case like antimonium tart, same kind of air hunger, same kind of generalized pneumonia, but there are certain differences. You would have the same kind of pitched appearance, same respiratory embarrassment, that is ARDS, the same kind of flapping nose, the same kind of cyanosis. But as a rule, carboveg cases, there is less cyanosis to the extremities. It is more central and more likely to, and the carboveg case is more likely to be pale and covered with an icy cold sweat. It is icy cold sweat. And the first distinguishing point is that the carboveg patients say that they have intense air hunger and yet they feel frightfully cold, whereas there is none of that feeling of frightful coldness in antimonium tart patients. And instead of being frightfully cold, the carboveg patients want to be fanned, which means they would want a draft of air in front of their mouth. This is again another distinguishing point between carboveg and antimonium tart is that carboveg is going to have marked thirst while antimonium tart patient is thirstless. In carboveg patients, you mostly find that the sputum is just about as difficult to expectorate as in antimonium tart. But another distinguishing point in carboveg is that there would be plenty of flatulence. There would be plenty of flatulence in abdomen in carboveg, but there would be plenty of nausea in antimonium tart. Both carboveg and antimonium tart would like to be propped up, but the carboveg will allow you to put up a single blanket up to keep them warm, where antimonium tart cannot tolerate to get warm. It does not want to be covered. So carboveg would like to be covered and the face to be fanned, while antimonium tart would not like to be covered at all. Another point about carboveg patient is that they always tend to sleep into an aggravation. They doze off and they wake up with a aggravation and gasping for breath. In carboveg also, you have a failing heart. So carboveg and antimonium tart both are also very good medicines for shock. It is astonishing that how quickly patients respond to carboveg and antimonium tart. It is usually a question of acute heart failure, and either the patients respond at once or else you should give one of other heart failure drugs. What Borland says, I should expect one of these carbo-based patients with critical collapse to be out of danger within 12 hours. And he is right. I have seen patients getting out of danger within 12 hours. If the medicine is right and the potency is high and the potency is repeated. And see what Borland has said. As regards potency in carbo-based, one is dealing with an acute collapse. There is a dilating heart and a heart failure, and one must obtain an effect fairly quickly. So my personal preference is to go high and give frequently until I get a definite response. I would give CM every 10 or 15 minutes until I got a definite response, and that's the way to do it in emergencies. That's the way I do it in emergencies. That's the way I've seen my father do it in emergencies. And that's the way I've seen homeopathy overcome grave and gravest emergencies. The kind of response one gets is that patient begins to feel warmer, they become less cold, and the sweat begins to disappear. So this is the good prognostic indicators when the patient is responding well to carbo-based. Then what Borland would say, then I would space the drug out and give it every half hour, then 1 hour, then 2 hours, and slowly phase out the medicine. As a rule, you get the patient through the crisis in 12 hours. It is as a rule for Borland to get a patient out of his shock, cardiogenic shock, in 12 hours with carbo-based if the patient requires carbo-based. Otherwise, his medicine is wrong. He says so. And he says, I've tried low potencies in cases of this kind and the patient did not respond at all. I have then jumped up to a CM and the drug has immediate effect. So to have result like Borland, you must give frequent repetition to begin with, and you must keep up your action for some hours, giving CMs all the time in acute emergencies, provided the patient is robust. Antimonium tart cases are not so acute. In them, you are dealing with a waterlogged chest rather than a sudden cardiac failure. So in them, 10 m would be sufficient and CM is not required. I think Kalikar, coming to Kalikar, I think Kalikar tends to be indicated from about the 5th day of disease onwards, like the previous two. Very often, it is a case which has responded to a certain extent to one of your previous drugs, but you are not satisfied with its progress and the patient is still running a temperature, and although more uncomfortable, it is not clearing up. Now the appearance is rather pale, haggard, exhausted appearance. There is a puffiness in the face, and especially the lower eyelid, they become puffy. These patients of Kalikar, they dislike being alone, they are easily irritated, and they are sensitive to any noise. Their lips tend to be cyanotic, dry and cracked, as you can see in the picture, and this is deep kind of cyanosis. Their tongue feels to be scalded, that is, it is dry, red, and has a burnt feeling. The patient have dry mouth, burning mouth, but are not thirsty, though they may want a little sip of water here and there. Their cough tends to be very dry and suffocative in type. And what is very particular is with a bout of coughing, you would find these patients breaking out in profuse sweat. The sputum is scanty, difficult to expel, and often it does not come up to the mouth and it is swallowed down the esophagus. The Kalikar patients are very sensitive to any draught of air. It produces violent attack of coughing. Then there is the typical position of Kalikar. If the patient would always want to sit upright, they lean forward and they support themselves with their elbow on their knees. Or If they have a bed table, then they would lie across the bed like this. So these are the two typical postures of Kali Carp. They have violent chest pains with their cough. The pains are very much aggravated by any motion, and of course, they are produced by any kind of draught of cold air. In Kali Carp, as a rule, there is no involvement of lung. It is purely the no involvement of the heart. It is purely a lung medicine, and heart is not at all involved. The the classic aggravation time of Kali Carp is between 2 to 4 o'clock. When you have indications for Kali Carp, you are not dealing with an acute emergency, and in consequence, you do not need your highest potencies. I would give 1 m to older Kali Carps, patients who are old, who are receiving Kali Carp. Borland would give 1 m to them. The average younger patients would, robust patients would need 10 m to be repeated in the usual way, that is every 2 hourly. Then coming to Lycopodium. Now in pneumonia and cough, Lycopodium is quite similar to Kali Carp. In appearance, they give you an impression of being anxious, worried, and they have a perpetual frown. You can see this gentleman having a frown, a kind of a vertical ridge in his forehead. The lips tend to be cyanosed or somewhat dusky in appearance. It is a look of an ARDS patient. Now, classic facial appearance of Lycopodium is told to be sallow. Now, what is sallow? Now, sallow skin is a yellowish ash brown in appearance with wrinkles. Now, you see on the left side is the sallow skin. On the right side is the healthy skin. You see this is brown, yellow, wrinkled, grayish type of skin. Now, this is Lycopodium sallow skin. The mentality of the typical Lycopodium pneumonia patient is a little difficult to get hold of, because although they are anxious, very worried about themselves, they are wanting attention, wanting somebody to be about, but they are very peevish, very irritable, and especially irritable to people who are trying to help them. This is something which is very striking about Lycopodium. Their nose is also pinched like antimonium tart. So they have a pinched appearance like antimonium tart, but the nose is a bit dusky and not sooty, although this is a very fine difference, very hard to distinguish. But very easy to discoloration of teeth and a sour taste in the mouth, and the tongue tends to be coated white like antimonium tart. Lycopodium has variable thirst. If they are thirsty, they prefer warm drinks to cold drink. If they have much to drink, it is very apt to produce a sensation of fullness and of flatulence. It may actually produce a sense of nausea too. The respiration in Lycopodium is very difficult, short, panting, labored breathing. They complain of a feeling of tightness in chest or even an actual sensation of constriction of the chest. The cough is always very difficult, paroxysmal, violent, spasmodic cough. The patient complains of intense rawness in the chest after coughing. The sputum is always scanty, tough, and very difficult to get up. And it is very often yellowish gray blood-stained sputum. Frequently, the patient tells you that it definitely tastes salty. Now, there is a small remedy wherein the sputum, the picture of the cough is like Lycopodium, but the patient who say that sputum is tasting sweetish. Think about stannum at this point of time. As a rule, patients, lycopodium patients are chilly. They are sensitive to cold, but they dislike a stuffy room. Usually, the sweating is very less in lycopodium. And mostly you would find right-sided pneumonia in lycopodium cases. As a rule, these lycopodium patients are very uncomfortable if they are lying on the back. They are very much better sitting up. Any patient having late pneumonia would be comfortable sitting up. Then there is the typical aggravation time of lycopodium, which is 4 to 8 actually. Borland has written that it is between 4 to 6 in the evening, but then he later on says very often the temperature swings up about to states and stays up until about 8 o'clock and then begins to drop. So he also knows that the typical time of aggravation of lycopodium is 4 to 8 o'clock in the evening. As regards to temperature, it's a medium height kind of temperature reaching about 103 degrees centigrade or 103 degree Fahrenheit. And lycopodium cases respond well to 10 m's repeated 2 hourly. Then come to arsenic album. Now arsenic album, according to Borland, is required only in the collapsed state of pneumonia crisis. You seldom get indications of it during an active stage of pneumonia. But here I would beg to differ, because in this COVID-19 scenario, we are getting definite indication of arsenic album in the active stage of pneumonias. If you are going to repertorize over each of the cases that come to you, you would see arsenic album propping up quite frequently. Now, the picture of arsenic album is very typical. You all know that. It is intense mental and physical restlessness. There is a fear of death, fear of something bad might happen. The patient is certain he is going to die. He wants attention, wants somebody there. He is afraid of being left alone and wishes to goodness you would get on something for him. And he's almost, lamenting, craving for care. As a rule, the patients are pale and they are not livid looking. They are somewhat cyanotic, but their skin is cold and covered with cold, clammy sweat. The lips are usually cyanotic. Often you will see them looking rather shrunken, shriveled looking, and actually bluish. So they have a puckered kind of lips which are cyanotic. The patients keep shivering with cold. They want to be covered up. They cannot bear any draught about. The characteristic thing about the tongue in the arsenic case is its dryness. The patient complains mouth feeling burning hot and dry, and in spite of this great dryness, great parchness of the mouth, the patient wants to sip a small amount of water frequently. And in spite of the general chilliness that the patient is feeling, the patient would want to sip cold water, as cold as he can have. Initially, arsenic patients have a violent suffocative cough which makes them sit up in the bed feeling as if they are going to strangle. In late stages, you will very often find the patients hardly coughing at all. They do not seem to have sufficient strength to cough. Cough is very useless and brings up no sputum at all in the later stages of pneumonia. They always complain of intense constriction in the chest. It feels horribly tight, as if they could not breathe at all. After coughing, or even when they are lying still, they often complain of burning pain in the chest. The sputum is always empty. There is tremendous weakness of the chest. The collapse in the arsenic cases is very liable to take place in the early hours of the morning. It is usually between 1 and 3 o'clock in the morning. And in emergency ICUs, 1 to 3 o'clock in the morning is supposed to be the worst time. It is the time then where maximum deaths take place. Well, this is a picture as you see it. And there is a warning that Borland is giving you. If you have a case of that sort, a case of collapse, wherein arsenic album is indicated, if you have a case of that sort with definite arsenic album indications and you prescribe arsenic album and get a reaction taking place, unless you follow that arsenic patient up with another drug, within the next 12 hours, you will find your collapse reoccurring, and then you will find that your patient does not respond to a repetition of your arsenicum and the patient will die. And this is something to be understood and followed. Please do not experiment with this rule because patients do die if you keep on repeating arsenic and do not follow up arsenic in collapse stages or in advanced cases. If you keep on giving arsenic, patient is going to die.
Yes, sir.
Ma'am, there are only 2 medicines left. I can skip them or I can just rush them through.
Yeah, let's rush them through and complete it, sir, I guess.
Okay.
We can.
So now we are coming to sulfur. And it's a straight sulfur pneumonia. The appearance of the patient would be dirty, as you would see that the patient is dusky and dirty looking. The orifices, all the orifices would seem to be red. They are red and inflamed. And there is a sense of intense weariness in sulfur patients. They always complain of a dry mouth, which is often offensive. Tongue is usually thickly coated with intense thirst. And you would always see that hot burning foot, which is stick out of quilt. You do at times find that the state in your sulfur pneumonia patients, how much more commonly you find that you have alternating state of heat and cold. So it is that irregular distribution of heat and cold which is typical of sulfur pneumonia. It is not always hot. Sometimes it is going to be hot, sometimes it is going to be chilly. So this typical hotness of sulfur is not going to be seen in pneumonia patients, sulfur pneumonia patients. The sputum is scanty and it is associated with acute pain in the chest, as if something is stuck through the chest. And herein you may confuse it with chelidonium. But chelidonium has intense pain stuck through the chest on the right side from the front to the back, while sulfur you would have it on the left side stuck from the front to the back. Then there are 2 typical symptoms of sulfur. The sulfur patients are very liable to have their first paroxysm of coughing after they have gone to sleep. Another is that very often after being asleep, they wake up with a horrible feeling of pulsation in the chest, accompanied by pretty acute anxiety and feeling as if they are going to die. Now, there is one odd thing, oddity in these sulfur pneumonias, and that is, in spite of the fact that they often wake up in this acute distress, they quite frequently tell you that while they are asleep, they have singularly pleasant, peaceful dreams. It is about the only drug in materia medica that we know which has peaceful dreams in a distressful condition like pneumonia. And the patient is always going to have ARDS, acute air hunger, and the maximum impact of sulfur aggravation would be at 5 o'clock in the morning. Sometimes it is also at 2 o'clock in the morning. Patients are always sweaty. The sweat is hot and it is very offensive smelling. And there are a few cautions here. Although the sweat is hot and smelly, the patient would not like to be bathed. And if you are insistent on, or if the nurse is insistent on giving him a bath, then you must tell the nurse not to do so. Because if they are given a bath, they would have an aggravation in both their fever and in pneumonia. And sulfur is also, very exhausted. So sulfur find it very exhausting to talk to other people. So also with sulfur patients, do not allow many people to go to them or to visit them. Anyway, in COVID-19 scenario, people are quarantined. So in an acute stage, sulfur patient responds remarkably well to the very highest potencies like CM, repeated every 2 hourly. But in a stage of exhaustion, it is wider to administer 1M instead of the CM at the same interval of 2 hours. So this is a quick review of Borland's Materia Medica and Borland's classification of pneumonia and the medicines that he has prescribed. I have tried to be very, very quick, but I think I've yet taken 2 hours. I'm sorry about that. Dr. Ria, you may come and join us.
Thank you so much, sir. It is evident that you have put in a lot of effort in this presentation and all the sessions. We are very thankful to you for doing this for us. Thank you so much, sir. And I am sure that you have a lot of work and it's already 2 hours, but we have 1 or 2 questions if you would like to take. So one question by a learner is that some remedies have mentioned that they work best in low potencies. So can they also be given in high potencies?
Borland has a very clear answer in his book. In the book that I'm talking about. He says it doesn't matter what authors mention. If the medicine is right and you are sure about the medicine, if you are sure about the use of the potency, it works in all the potencies, whether high or low. Like initially I was told that Hipersulf works like Cilicia if given low in 6 potency and works like absorption of pus if given high. But what I've seen recently, I've prescribed Hipersulf to somebody in very high potency, CM potency. And what I've seen, it is the body is an intelligent being. It takes its own decision. So if the medicine is right and the body needs to expel the pus, it's going to expel the pus, whether the Hipersulf is 6 or whether it is CM.
Yes, sir. Thank you, sir.
It doesn't matter. It doesn't matter.
Okay.
If you follow a proper potency scale, then I mean the chances of aggravations are not there.
Okay. So a learner wants to know what levels of SpO2 up to what level manage with homeopathic treatment and without oxygen support?
Till 92. SpO2 92%. I would say is safe for a beginner, but till 90, I would say homeopathy works very well. You can do it at home. Although I have tackled patients with SpO2 80 at home, and they have come through because patients don't want to go to the hospital. First, their hospitals are expensive. The other is that they are terrified of the medical system. So many patients don't want to go to the hospitals. So they would ask you to do the needful. So if you are confident, you can give them oxygen in the home setting also, and give homeopathy, and you would see wonderful things happening. And especially with patients wherein antimonium tart, carboveg, calicarb, etc. indicated nebulization. And why go in for oxygenation? You simply go as soon as the patient comes to say 92, you go in for nebulization. And I mean, there is no harm in using the supportive techniques which are used in modern medicine with homeopathy. And this was being done with when Borland was active in his hospital. They were using at that time oxygen was the thing that was used supportively and IV fluids. So he was using IV fluids and he was using oxygen. And he is specifically written with Carboveg in his book that Carboveg patients always require oxygen support, which is true because the patient is going into shock, he's getting cyanosis, so he would be requiring oxygen. So they were doing great work. But sadly, in India, people, especially the government, people believe in homeopathy. The government doesn't. So we are not given a chance to work in ICU. Otherwise, we can be a great help to people in ICU.
Yes. All right, so I guess we have taken a lot of questions. If you have missed any part of this presentation, you came late, anything like that, you can watch the recording in a few days on our website itself. And if you have registered for this webinar, which you must have, then you will receive the replay link for this session on your mails 24 hours later. So don't worry, you'll not miss out on anything that we learned today. Again, I would like to thank you so much, sir, for giving so much effort and time. And we really learned a lot from you. Thank you so much, sir. And hoping.
Just before leaving, there is a small message.
Yes.
2020 has been a bad year for us as doctors. We have faced challenges. If you remember, I remember when we were studying PSM, it was a goal of WHO, health for all in 2020. It is, death and disease for all in 2020. So God has kind of, shown his wrath. I hope 2021 is going to be a better year. एक ब्राह्मण से सुना है कि ये साल अच्छा है. So let us hope कि गालिब ने जो कहा है वो अच्छा हो और next year हम लोग के लिए अच्छा हो. We are through with this disease, but as doctors we have to be prepared and vigilant for future things to come. We must keep on studying, and I would wish all the people who are here, who have been joining us over the time, over the webinars, and people who are still here, to just lay down their intelligence and their reasoning in the feet of great masters like Heinemann and Kent and Borland and Burnett and so many great past masters. And you would see once you bow down and surrender to their thought and their reasoning, and you adapt that reasoning to the modern world, and adaptation is important. If you just start adapting those principles to the modern clinical scenario in 2021, I wish from the bottom of my heart, and I pray for you all, that you all become great healers of times to come. All the best to you all. Thank you very much.
Thank you so much, sir, for your wishes. Happy New Year to you as well.
Happy New Year to you all. Thank you. Happy New Year to you, Dr. Yeah. Bye-bye.
Happy New Year, sir. Bye-bye. Take care. So everyone, as you heard, Dr. Harsh Nigam has a lot to teach us, has a lot to offer. So don't miss out on learning from him in his online course with the Homeopathic Academy, Modus Foundation and Modus Prescriber. You can visit our website. I've mentioned the website link in this chat. I'll mention it again. Also, as you can see on your chat screen, we have a special Christmas and New Year offer for you all. You can enroll and use the coupon code NYO30 on the checkout page to get a flat 30% off on our courses. This offer stands till 3rd January only, so go ahead and enroll in Dr. Harsh Nigam's online course before the offer ends. And let's hope everybody has a great new year. Let's keep learning, keep improving together. That's our motto at THA for you all and for us. So thank you, everyone. Thank you, Dr. Nigam, again for being with us. Thank you, everyone. Take care. Have a great day. Keep learning.